Welcome to the AIDS Clinical Conference. I want to go ahead and just dive right in and introduce our speaker this morning, Dr. Brian Wood. For many of you in this area, you are very well acquainted with Brian and his excellent teaching and leadership in the HIV field. Brian went to medical school here at the University of Washington. He did his residency, and he really pioneered the first HIV track and residency here at the University of Washington, which has really been something that has benefited a number of residents subsequently, really in the last 5 to 10 years since he did this. Brian then subsequently went to the East Coast and did his infectious disease training at the Mass General Harvard system and really accomplished a lot there and began to really distinguish himself as an outstanding clinician and educator in the field of HIV and AIDS and in infectious disease. Here in Seattle, Brian has been the leader of the outstanding ECHO program in the field of HIV and has really garnered regional reputation and national reputation in his leadership in this ECHO field. It's a really innovative program that under John Scott's leadership here at the University of Washington, Brian has really taken the HIV program and run with it and done an amazing job. He clearly is an outstanding educator, and today he's going to give us an update on really where the future of antiretroviral therapy is going. And welcome, Brian.
Thanks so much, David. That's a huge honor. And I really feel honored to be asked to do this, having sat in the audience as a medical student and a resident. And now to be asked to give this talk is really, really flattering and an honor. And many of my mentors are in the room, so thank you. And if you all humor me, I'm going to try something a little new in this ACC, and I'd like you all to answer some questions along the way. I will ask you some questions that have no right answer, and I'd love for you to weigh in. So if you could please, on your phone or mobile device or whatever you have, either go to this website, polleverywhere.com, and log in, or you can download the app and log in, and we'll give that a go. To start, I have no financial conflicts of interest. I will be discussing investigational ARVs, and the other thing I want to highlight is I really am going to be focusing on antiretroviral treatment. I'm not going to have time to talk about new meds for PrEP, and I'm really not going to talk about HIV cure strategies or immunotherapy or things of that nature, or really antiretroviral implementation and adherence, which is a huge, huge important topic. But really the focus of this is going to be new antiretroviral agents, where we are, where we're headed in the near and more long-term future. Another thing to note, a lot of the slides that I will be showing you are from the National HIV Curriculum, led by David Spock, and like everything that David leads and produces, it is of an incredibly high caliber and quality. And I would lead you here to see more about the drugs, to learn more about HIV care, and for some really useful clinical tools. But this is what I'll talk about. And again, I'm going to ask you for your input on things, but where are we with antiretroviral therapy right now? What are the gaps? What do we still need? And then where are we going in the future in terms of new oral meds, and can we improve on what we have now? Long-acting injectable meds, which I know everyone is eager to talk about. And then this data that's coming out for treating people with only 2 drugs, either at start or as maintenance. And I'll discuss sort of why we're focusing on that now and what we know and don't know. And of note, I think by spring 2018, we'll probably see at least 3, maybe 4 new drug approvals. So I'll focus on some of those. But first question, and we'll see how this works. So on Poll Everywhere at the website or the app, the login is UWACC. Whether you are a prescriber or not, and for those logging in remotely, please weigh in too. Here's my question for you. Somebody needs initial antiretroviral therapy. Let's say they say, I will take whatever you recommend. This might be a patient, a client, a friend, a family member. Which of these options would you recommend to them? And I have abbreviated the NRTIs, and so I'll just talk through this quickly. It's hard not to use abbreviations with ARVs because the names are so darn long. But so this dolutegravir, bacavir, 3-TC or lamivudine is Triumec. This is dolutegravir plus Truvada, dolutegravir plus Descovy. This would be Stribild, Genvoya, raltegravir and Truvada, or raltegravir and Descovy. So please weigh in. Again, there's no right answer. For those of you in the audience and watching remotely, I'm very curious to see what you would say. All right, I see the results coming in. Thank you, everyone, for weighing in. Let's go ahead and take a peek. So those in the room and logged in remotely are most commonly prescribing for initial therapy dolutegravir plus Taff FTC, which is Descovy, and then a smattering of other responses here, but I think most commonly dolutegravir plus Descovy. And in my experience, that is pretty consistent in the region and the community. So let me just start with where we are right now with antiretroviral therapy. This is a summary of the most recent ART guidelines for initial therapy, very recently updated by the Department of Health and Human Services just in October with their new categorization of regimens recommended for most people. And then this is the IAS USA guidelines, last updated July 2016. And clearly, we are in the integrase inhibitor era. Now, every anchor agent recommended by both guidelines is an integrase inhibitor, and we'll talk about why. You can see the real difference between these guidelines is the emphasis from the IAS USA that we should be starting people on TAF if it's feasible. The HHS guidelines, they say less strongly that we should be veering towards TAF. But I think as everybody voted, most people are leaning towards TAF for initial therapy if it is available and feasible and accessible. Now, why have we shifted towards integrase inhibitors? Why have NNRTIs and boosted PIs fallen off the recommended lists in the guidelines? So this is just a summary of what we have for treatment-naive studies for integrase inhibitors being compared to anchor agents like efavirenz and boosted PIs. And you can see here the efficacy based on virologic suppression generally favors the integrase inhibitor. I should say always favors the integrase inhibitor, with the stars being statistically significant. But even when not significant, really does favor the integrase inhibitor. And most of this improved efficacy of integrase inhibitors is because of tolerability. So we have seen in a number of studies that integrase inhibitors work better for initial therapy. And then over time, in data included work from Heidi Crane and others here, we know that integrase inhibitors over time lead to reduced rates of virologic failure, resistance, and regimen changes. And for example, if we talk about dolutegravir, which it sounds like everyone is leaning towards for initial therapy, there still to date have not been cases of resistance to dolutegravir documented in people who started dolutegravir for initial therapy. There's one case report that I know of. But really, resistance to dolutegravir for people who started as initial therapy is incredibly rare, to the point that if you find it, it can be a case report. So clearly we're in the integrase inhibitor era. At least in my practice, we're also in this era of, should we switch to TAF? And I think that question comes up a ton. So I'd like you to weigh in on this too. So here's a statement. All patients currently taking TDF should switch to TAF. Agree, disagree. Again, no right answer. I'm very curious what everybody will say here, because I think this question comes up a ton, and I've been asked this by clinicians here in the community. So do you agree that all patients currently taking TDF, the older version of tenofovir, should change to TAF or tenofovir alafenamide, the newer version? And thanks everybody for weighing in. I'll just give that a couple more seconds, and let's see how everybody voted. So that's interesting. So that's kind of a almost 50-50 split. So I think that shows how divided we are in that statement, how unclear it is, and how no one really knows the right answer. Let me just talk a little bit about TAF to get everybody updated. I'm not going to go through all the data, but this is a really nice slide from David Spock. And just a reminder that what we're talking about with TAF or tenofovir alafenamide is a new tenofovir prodrug that gets converted to active metabolites by a different enzyme and really in the target tissues, the places you want it. What that means is much lower circulating plasma levels of drug and thereby lower levels in the kidneys and bones. So higher levels the places you want it, lower levels the places you don't want it. So a quick summary, what we know about TAF in many studies, and I'm not going to show you, the virologic efficacy is similar to TDF. In terms of the side effect profile, it does appear that when you look over time at markers of renal proximal tubulopathy and bone mineral density, that TAF is beneficial over TDF. It is a little bit worse in terms of lipids, simply because it doesn't have as much lipid-lowering property as TDF. TDF has some accidental lipid-lowering effects, and so you reduce those effects when you switch to TAF or when you use TAF. TAF has been studied in mild to moderate renal impairment with creatinine clearance down to 30, although even in that study, most people did not have a creatinine clearance pushing 30, so when we get down near that, we do get a little nervous, but it is approved by the FDA for mild to moderate renal impairment, also approved for chronic hepatitis B. I think what we're really missing with TAF is long-term clinical outcomes data. Does this change in side effect profile lead to lower rates of things like osteoporotic fractures, cardiovascular events, with the lipid data and things like that. So the long-term clinical outcomes are what's missing, and then we don't have data yet for PrEP for TAF, which everybody's eager for, but I won't be talking a ton about that. So I think there's some different camps, and our poll sort of shows different viewpoints with TAF. I think some people really have a glass half full, this is a clear improvement over TDF, we should be switching everyone, and others are a little more wary and really want to see some of this long-term clinical outcome data. I don't know about you, but in my clinic, I feel like I'm putting people sort of in three groups. The people I'm really worried are having TDF side effects, whether it's kidneys or bones, and I'm really pushing to change to TAF. There's the people who aren't really having any changes, but maybe they're getting older or have other risk, and I'm getting worried they could, and I'm sort of nudging them to switch. And then there's the younger group with no evidence toxicity, not really much risk. They're on TDF, they're suppressed, they're tolerating it, and I don't know. I think it's debatable whether they should switch or not. And I kind of think if it's accessible, why not? But I don't really push people. But that's sort of my triage in my clinic. But as we showed in the poll, there's really no right answer. Just a reminder that the TAF formulations are smaller. And so for people having trouble swallowing or having trouble with pill burden, they can have that benefit. So this is just to show relative size. I think, just summarizing where we are now, I think clearly we're in an era of integrase inhibitors. We're in an era of very high efficacy of first-line regimens if people can adhere. We're also, I think, in this era of a lot of conversations in clinic of really trying to get people on the simplest, best tolerated regimen with the lowest short and long-term toxicity. So lots of discussions about switching, about updating, about switching from TAF and switching other agents. And we're really thinking about long-term toxicity. Now, I think ART is clearly better tolerated than it was in past years. It is still far from perfect. Although we're in this integrase inhibitor era, there are lots of reports now about integrase inhibitors leading to neuropsychiatric side effects, especially dolutegravir. I think the biggest limitation I see in my clinic is the headache and the insomnia side effects. There's also now some reports about integrase inhibitors, especially dolutegravir, may be leading to weight gain, though I think that data is really preliminary. We have summarized all of that data in short talks on our ECHO website, so you can go to our ECHO website and see short 15-minute talks on these issues. And as you know, there are still many, many individuals who struggle with adherence. So we do need new interventions and new agents that will help optimize adherence. So that's my short summary of where I think we are now. There are as well a few individuals out there, they don't come up a ton in clinic, but who just have so much resistance they don't have any options left. Luckily, those cases are few and far between, but I do think that comes up. That's my summary of our current era. What is the next era going to bring? And really the biggest question I want to ask you is, what do we need the most? So I've summarized here in another question I'll ask you to respond to some things that I think are coming. So here's my question for you. Which one of these do we need the most? Or which one of these is going to make the biggest difference in care and treatment and HIV outcomes? So here's the options I've given you, and we are going to talk about what's coming in each of these categories. New oral meds from existing classes that improve upon what we have now. Meds with totally new mechanisms of action that could be an option for those people who have resistance to all the current classes. Long-acting injectable meds that offer reduced frequency of dosing. Or more data and guidance for how to use these two-drug ARV strategies, either for initial or for maintenance therapy. So this is a couple of categories of things I think coming in the near and more distant future. Which one of these is going to make the biggest difference to HIV care and outcomes? Or which one do we need the most? All right, thanks everybody for weighing in. I'm curious to see answers here. All right. So I think there's a bit of a split here. No one's overly excited about new meds from existing classes, which is interesting. We will talk first about what's coming there, but then we will switch and we will talk about some long-acting injectables. I think everybody is excited about those. Everybody's eager to see those become available. I will warn you, I tend to be a little more on the skeptical side about these, and I'll talk about why, but I do think they may play a role. And then meds with novel mechanisms of action and data and guidance for dual ART sort of tied there. So that's very interesting. So thanks everybody for weighing in on that. So here's a short summary, not an exhaustive list of things that are coming in the future, and I'll talk more about some of these. Things that are in phase 1 and phase 2 don't always move forward, so I'm not going to spend much time on these, but I do think there are some very interesting things here. Long-acting agents in existing classes. a really interesting drug that blocks not only CCR5, but also CCR2, which has been implicated in inflammation and is being studied actually outside the realm of HIV to treat NASH and other inflammatory conditions. And then lots of other things in early stages of development, but I'll focus your interest over here on the things that are either in phase 3 or moving into phase 3 or beyond phase 3. And we will talk about oral meds in existing classes like bictegravir and doravirine, new formulations, oral meds with totally new mechanisms of action, and of course the dual therapy. And then I think what everybody's really eager to talk about, the long-acting injectable agents, either those that are IM, IV, or sub-Q, and we will talk about those. I've starred the ones that the FDA is likely to review soon, and I'll come back to those. But first, can we do better than the oral meds we have now? So let's talk about new meds from existing classes first. I'm going to focus first on bictegravir, a new integrase inhibitor that the FDA is likely to weigh in on sometime around February. So first, a study that compared bictegravir combined in a single tablet with TAF and FTC. So these are the NRTIs in, for example, Descovy. So bictegravir, TAF, FTC compared to dolutegravir plus TAF, FTC. So this is a randomized trial of treatment-naive adults randomized to either this new integrase inhibitor bictegravir or dolutegravir combined with these same two NRTIs. And we're going to look at data out to 48 weeks, which was their primary outcome. And you can see here the virologic efficacy by FDA snapshot at 48 weeks is very, very similar, not statistically different. Importantly, no participant in the study discontinued due to lack of virologic efficacy and no resistance developed. So it does seem like bictegravir, similar to dolutegravir, has a high barrier to resistance. And thus far in clinical trials, although we don't have as long-term of data as dolutegravir, again, people starting bictegravir as initial therapy don't seem to get resistant to it. One thing I really wanted to see was the side effect profile of bictegravir compared to dolutegravir. My experience in clinical practice and a number of studies would show that somewhere around 10% of people just don't tolerate dolutegravir. Depending on the study, 5 to 15% of people stop it, most common reasons being headache and insomnia, and I've definitely seen that in my practice too. So 1 in 10, 1 of 20 people, I think, just don't tolerate dolutegravir. We love it as clinicians because it's simple, it's forgiving, it has a high barrier to resistance, it's relatively devoid of side effects, but some people just don't tolerate it. So what I really wanted to see was less headache with bictegravir, which we didn't see here, and less insomnia with bictegravir, which we also didn't see. Interestingly, in this study, bictegravir did cause less change in serum creatinine as dolutegravir. We know dolutegravir blocks tubular secretion of creatinine and in a very benign way changes serum creatinine. In this study, bictegravir didn't do that quite as much, but that didn't hold true in all the studies. So switching then to another analysis that looked at bictegravir with TAF FTC compared to what we know as Triumec or dolutegravir with abacavir 3TC. I really liked this trial and I was eager to see it because it's not only a comparison of bictegravir and dolutegravir, it's also really the only comparison we have to date of TAF versus abacavir. So I liked this study for a couple reasons, and I'll show you some things we learned from it. Again, this is a randomized trial of treatment-naive adults. So this is initial therapy. Again, at 48 weeks, virologic response is equivalent. So I think we can conclude that bictegravir is as efficacious at controlling HIV as dolutegravir. If we look at side effects, we see a couple things here. Again, headache and insomnia are very similar. So I think we need more data, but I'm not totally convinced that bictegravir is an improvement in terms of tolerability over dolutegravir. There were more adverse events leading to treatment discontinuation in the dolutegravir abacavir 3TC arm. Most of that was because of nausea, and I attribute that largely to the abacavir. We know some people, even if they're B5701 negative, just don't tolerate abacavir very well. And interestingly, in this study, the change in GFR was very similar. Also, and I'm not showing you all the slides, but we do have them on the curriculum, the changes in bone mineral density, in proximal tubulopathy markers, and in lipids were really, really similar. So I think this suggests that TAF and abacavir have a similar risk profile when thinking about effect on kidneys, bones, and cholesterol. So the investigators who led this trial concluded that bictegravir combined with TAF FTC, the single tablet, which we are going to see in early 2018, was non-inferior virologically to dolutegravir abacavir 3TC, which is Triumec. It was well tolerated with fewer GI side effects than the dolutegravir abacavir regimen. And so just to add kind of my interpretation and a question for you here. So when I think about how much of an improvement this is, well, yeah, it's a potent integrase inhibitor in a single tablet with TAF. We don't currently have that. That is a step forward, but how much better is this than, say, dolutegravir plus TAF FTC, which is 2 really small pills once a day? I'll throw that question out to you to think about. How much of an improvement is this, and how will this fit into clinical practice? I think we need more data on the neuropsychiatric side effects. I'd really like to see data that bictegravir is better tolerated, especially in terms of headache and insomnia, than dolutegravir, and I'm not convinced of that yet. Interestingly, the investigators, when they presented at IAS, presented some patient survey data, and patients did report less use of sleep medication and sleep disturbance in the bictegravir arm. They didn't include that in their Lancet publication, so I don't really know what to make of that. It was patient survey, it was patient report. I think we really need more data on side effect profile of bictegravir and whether it's different than dolutegravir. We did see at ID Week a switch study from a boosted PI plus 2 NRTIs to this single pill, bictegravir TAF FTC. They're both very efficacious. It did improve lipids. And interestingly, those people who switched to bictegravir did report more headache, and they did have a minor change in GFR. But I'm not going to go through all that data. Those abstracts are available. I think in the near future, we are going to see more switch studies. There is a study of bictegravir TAF FTC in women that's fully enrolled and will reach its primary endpoint in early 2018. And the regulatory filing has been submitted to the FDA for a February-ish target. The other questions I tried to answer about bictegravir in terms of thinking about differences with dolutegravir. So one, does bictegravir interact with cations like we know a lot of the integrase inhibitors do? From what I've seen, it does appear that it does. In terms of the interaction with metformin, data does show that it interacts, but less so. So here's some data showing that the impact on metformin levels are less than with dolutegravir. It does appear to interact with rifampin, as does TAF. So bictegravir TAF FTC will not be a great option for individuals needing rifampin, such as for tuberculosis treatment. One thing, as far as I've been able to find, is that bictegravir is unlikely, at least at first, to be available as a standalone tablet. So it does seem like this combo, bictegravir TAF FTC, is likely going to be what we have. So I'll just throw this question to you to think about. How is this going to fit into clinical practice? So bictegravir, a potent integrase inhibitor in a single tablet with TAF FTC. I would say some minor improvements over dolutegravir, but it is 1 tablet a day, which people love. So will you use this for first-line therapy? Will you switch people to this? I guess I would say, why not? But if it's cost neutral, why not? But is it a huge improvement over what we have now? I guess I'm not totally convinced. Yeah, so Mina's question was how big the pill size is, and we don't know yet. We haven't totally seen it, but the bictegravir dosage is small, so we do anticipate, in terms of our single tablet regimens, it will be on the smaller side. And so that also may play into this decision. So thank you for that question. Yeah, so thanks, Sylvia. So the current recommendation, the question is about interactions with metformin. The current recommendation with dolutegravir is for somebody who, let's say, is on full dose metformin, is yes, to lower the dose to no more than 1 gram a day is what's in the package insert, and then over time you can slowly increase that back if tolerated. We don't have really strict guidance yet for bictegravir. This would suggest that perhaps the interaction is less and perhaps that's less necessary, but I think we'll have to see. But this has come up for me in clinic. For example, somebody recently who was still on TDF-FTC and a boosted PI, who has diabetes and is on full dose metformin, and we were thinking about switching to dolutegravir TAF FTC and talking about the metformin interaction. I ended up just saying, well, you're doing okay. Why don't we wait till spring and then do bictegravir TAF FTC? It's 1 pill with less interaction. So I think this may play into our decision some, but what we need to do with metformin dosing for people switching to bictegravir or starting, we don't know yet. So we don't know. So the other question about rifampin is a great one, and that's kind of why I threw this in there, that I think it's going to be hard to double if we don't have a standalone tablet. And then we do also know that rifampin interacts with TAF. There's some prelim data just from the European AIDS conference that maybe doubling the TAF dose may overcome that. So could we give 2 bictegravir TAF FTC tablets? I don't think we know yet. I think most likely this is not going to be a great regimen for people on RIF. But I appreciate those questions. Switching then to another new oral med from an existing class before we talk about injectables and other things. I just want to mention durvalin, a new NNRTI that has some advantages over what we have now, and I'll mention some potential benefits and some potential limitations. So here again, I'm showing you from the randomized trial of treatment-naive adults. In this study, randomization to either a single tablet of durvalin with TDF, and I think that's an important point, durvalin is being combined with TDF, Doravirine with TDF-3TC or efavirenz TDF-FTC. So this would be a tripla. This would be a new single tablet option that's coming. And this is a study called Drive Ahead. We did see earlier data from a study called Drive Forward that compared doravirine to boosted darunavir. I don't know who comes up with these study names, but I'm not going to show you that data, but it's out there, and doravirine and boosted darunavir worked really well as initial therapy, and doravirine was better for lipids, not surprisingly. But let's see what happens when we compare doravirine to efavirenz. So first, in terms of virologic efficacy, you can see really there was no statistical difference in all comers or when broken down by baseline RNA or viral load. And that was important to look at because we know rilpivirine, which is in Complera and Odefsey, does not work well at high viral loads, and that's a limitation of that NNRTI. When we look at side effects, there were more study drug-related adverse events in the efavirenz arm. The general sort of side effects were really similar. What we were more interested in was the central nervous system side effects, and it does appear that doravirine is an improvement over efavirenz, not surprisingly, in terms of dizziness, sleep disorder or disturbance, or I could never quite figure out how they define this, but altered sensorium is the term they used. The difference in depression, other psychiatric events like psychosis, suicide, and self-injury was not statistically different. However, the numbers are really small. So I don't think we totally know the difference in terms of mental health side effects. But in terms of central nervous side effects, it does appear that doravirine is an improvement. So I don't know a target date for doravirine yet. There are other studies ongoing, like a study called Drive Shift that is switching people to this regimen. We do think, based on this study, that doravirine TDF-3TC is non-inferior virologically to efavirenz TDF-FTC. It does seem to have lower rates of some of those central nervous system side effects. I didn't show you the data, but the lipid changes also were better. But let me ask you just for thought, so how is this going to fit into clinical practice? So would you use this? Would you switch people to this? Would you use this as first-line therapy? There are some benefits of doravirine over the NNRTIs we have now, and I've listed a few. So unlike rilpivirine, unlike Complera and Odefsey, there's no food requirement with doravirine. PPIs appear to be okay. As we showed, it is effective at any baseline viral load. So I think those are improvements over rilpivirine. It does have once daily dosing, which is better than etravirine. And it is active in the setting of common NNRTI resistance mutations. So the common mutations that happen with efavirenz or rilpivirine do not affect doravirine. There are some mutations that can impact it, but if somebody has failed rilpivirine or efavirenz, doravirine should retain activity. So it's once a day, and it's active in its common NNRTI mutations, so more like a once a day etravirine pill. I think we need more data on mental health side effects, and I think the biggest limitation here is that it was combined with TDF, not TAF, as in the bictegravir study we talked about, and their comparison data so far is to efavirenz and boosted darunavir, which are no longer on our list of recommended agents. So those, I think, are the limitations. I do think the company that has made this drug will likely do more updated studies, but to me, I think it's hard to know how it will fit into clinical practice based on those limitations. The one thing is, as far as I've been able to find, doravirine, unlike bictegravir, will be available as a standalone tablet. And I actually think it's going to be more useful in that regard. So all those salvage situations where we're putting rilpivirine in as an active NNRTI, why not use doravirine, which doesn't have the food requirement, the PPI interaction, and things like that? Or maybe as TwoDrug therapy, which we're going to talk about. What about doravirine dolutegravir as TwoDrug therapy, or doravirine boosted darunavir? I think that has potential, but I think we need to see more. Nina. Yeah, Nina's question is a really good one. It's about drug interactions with doravirine. So preliminary data makes it look really clean. And so I haven't seen data with hep C therapy, but for example, I think a big limitation of etravirine is you can't combine it with dolutegravir unless you have a boosted PI in the mix. That does not appear to be true with doravirine. Doravirine and dolutegravir appear to be fine. So I anticipate it is going to be an option and going to be okay with hep C therapy, but I haven't seen a lot of data yet. But I appreciate the questions. And before we talk about injectables, I'll just mention a couple other formulations that are coming so you're aware of them, or that are already out, just to make you aware. So this pill, darunavir cobicistat TAF FTC, this single tablet regimen with a boosted PI with TAF and FTC as the NRTIs, I don't know who comes up with these drug names, but which is being called Sintuza, will likely be reviewed by the FDA in early 2018. It is already approved in Europe. The FDA wanted to see the full treatment-naive study data, which was just presented at the end of October in Europe. And so I do think that the FDA will now move forward in reviewing this, but it has been a slower process here than in Europe. And so I'll just ask you the question too, how is this going to fit into your practice? Potent boosted PI, so high barrier to resistance, the benefits that we know of TAF and single pill, but in the era of dolutegravir, bictegravir, how is this going to fit in? I don't think we totally know. And then just to make sure everybody's aware, there is now a once daily formulation of raltegravir. So anybody who's still on raltegravir, taking this twice a day, there is this option for a once daily high dose form being called Ral HD. So we know from older data from Joe Aron that taking those 2 raltegravir 400 milligram pills once a day was not as effective as taking them as 400 BID, which is what we've always recommended. So now there is this formulation that's 2 600 milligram pills once a day that does appear to be effective. Anybody have anyone on this, written a prescription, or have anybody on this? I've written 1 prescription for it. Now that we have dolutegravir, I don't think we use it that or need it that much. Okay, so now what everyone's probably a little more eager to hear about, let's talk about long-acting injectable therapy. And I'm going to show you this study called Latte 2. If this looks like a complicated slide, it's because it was an incredibly complicated design and study. So I'll talk about a few things here. So this was the phase 2B trial, and I'll talk about the phase 3 trials that are ongoing. So this was an open label trial of antiretroviral naive adults. You can see here the inclusion criteria. And so a big consideration with these long-acting injectable meds is they are incredibly long-acting. We're talking they stay in the system 6 to 12 months. So if you give somebody an injection and they have a side effect, there's no getting rid of that drug. Because of that, everyone is going to need an oral lead-in period to make sure they tolerate the therapy, at least with these agents. Because of that, the way the study was designed was this 20-week lead-in phase. So 20 weeks, that's not trivial. So 20 weeks of taking oral pills, initially with oral cabotegravir with a 2-NRTI combo being abacavir 3-TC. At week 16, rilpivirine was added for 4 weeks to make sure a person tolerated all of the agents that were going to be used as long-acting injectable therapy. So if a person between week 16 and week 20 had a suppressed viral load and was tolerating the pills, then they were randomized to either stay on oral therapy or switch to long-acting cabotegravir and long-acting rilpivirine intramuscular injections. So these are 2 intramuscular injections in the glute every 4 weeks or every 8 weeks. But one of my concerns I'll throw out there about injectable therapy is if we're really targeting people who struggle with adherence, but then we're saying you need 4 months, 5 months of oral therapy first, how much of a limitation is that going to be? And is that going to dictate who we are able to offer long-acting injectable meds for? Now, we don't yet know exactly how long that lead-in is going to be, but this is what was done, at least in this trial. I think the other question and concern that comes up is, well, what about the person who takes injectable therapy and then falls out of care or misses a dose? These are very, very long-acting. They stay in the system a very long time. So what kind of oral tail is going to be needed if we stop these? And what happens if a person just disappears and doesn't take any oral tail? Now, looking at this trial, coming back to this, what you can see here in terms of virologic efficacy at 96 weeks, which is now published, in those who got long-acting injectable 2-drug maintenance therapy every 4 weeks, every 8 weeks versus staying on the oral therapy, these virologic response rates were not statistically different. So all of these appeared to be similar in terms of virologic efficacy, at least based on viral load suppression. There was some concern about the every 8-week dosing based on pharmacokinetics and also based on those who actually had virologic failure. So if we look at the viral response rate, same as I showed you in the bar graph, in the every 4-week arm and in the oral arm, most of those who weren't suppressed at 48 weeks had simply no data. They had fallen out of the trial for some other reason, not virologic failure. There were 2 virologic failures in the every 8-week arm, 1 in the oral arm. The one in the oral arm had no resistance, but the two in the every 8-week arm actually had resistance. One with an integrase inhibitor resistance mixture that wasn't super clinically relevant, but the other one with significant NNRTI and integrase inhibitor resistance, which would have cross-resistance with dolutegravir. So there was initial concern about the every 8-week arm and whether that would be sufficient. This slide, just to mention that with these injectable agents, again, this combo is 2 IM injections every 4 or 8 weeks. In the glute, their injection site reactions were quite common, but they were not limiting for most people. Only 2 people dropped out of the study because of the injection site reactions. And overwhelmingly, when people were asked, were you satisfied with this therapy? Would you prefer this to oral meds? People said, yes, I still prefer this despite the injection site reactions. So the future of this long-acting injectable combination, which I think is the first we're likely to see. So these are the phase 3 studies. So Atlas of every 4-week maintenance is enrolled and ongoing. Atlas 2M, which is going to look at every 8-week dosing, compared to every 4-week maintenance, is planned. Last I looked, not opened yet. And then this study called FLAIR is switching people from dolutegravir, bacavir, lamivudine, which is Triamec, to every 4-week maintenance on these 2 long-acting injectable drugs. So let me ask you this, and I'd be very curious, maybe in the question discussion period, what do you think about this? How will this fit into clinical practice? I think the absolute ideal is that we have long-acting injectables that will improve adherence for our most challenging patients. My concern about that is how much oral lead-in do we need and how much oral tail do we need when these meds stop. And my concern is that if somebody, let's say, takes pills, gets suppressed, tolerates the meds, switches to 2-drug long-acting maintenance therapy every 4 or 8 weeks, 1, they've got to come back every 4 or 8 weeks for those 2 injections. And 2, if they fall out of care for, let's say, 6 months, these drugs stay in the system for at least that long. So if their viral load becomes detectable again, what is the risk of resistance? And with cabotegravir and rilpivirine, when people develop resistance, they get a lot of cross-resistance in those classes. So those are my concerns. When individuals have been asked what is going to be the biggest benefit of long-acting injectable therapy, actually qualitative data shows one of the biggest things is simply reducing stigma, and a very frequent response is that it is simply going to get rid of that daily reminder about HIV of taking pills. And so I do think there's an element here of empowering people, of reducing stigma, and that can go a really long way. But who are we going to target for this, I think, is not yet determined. So maybe it'll reduce stigma, combat pill fatigue, improve care transitions, people, transitioning out of the correction system, out of the hospital, people taking long trips. Maybe there's a role there, but I'd be curious to hear what you think in terms of who is going to be a good candidate for this. I have one person in my clinic who I've mentioned this to and who I think might be a good candidate. And this is a person who has very few options simply because of side effects and perceived side effects. But this person also has been suppressed for 20 years. So I really wouldn't hesitate to switch her to an oral lead-in and then 2-drug long-acting. And she comes to every visit. And so that's the kind of person who I wouldn't hesitate. The person who falls in and out of care and who is intermittently viremic, I have some concerns. But I'd be curious what you think at the end too. Let me quickly talk about agents from totally new classes and then 2-drug therapy. And we'll definitely try to save time for questions and comments. So there are a couple of agents in totally new classes that are coming in the near future. So fostemsavir, and this is a diagram from the HIV curriculum showing the steps of viral entry in our current entry inhibitors like maraviroc and infevuritide. So fostemsavir is an oral drug that binds to viral envelope GP120 to prevent initial attachment of HIV virus to the CD4 cell. So this is very different than the entry inhibitors we have now. It doesn't rely on viral tropism like maraviroc. It doesn't have all the injection site reactions that limit infevuritide. It is an oral twice daily pill that is being studied for salvage, but I don't know an FDA target date for that one yet. Ableism, on the other hand, is an interesting drug that is a humanized monoclonal IgG antibody that binds to the CD4 receptor, but at a different site than GP120, so blocks viral entry in, again, a novel mechanism. This has been given FDA priority and orphan drug status. The FDA initially was going to review it in January. Now they've delayed that till April, but I do think sometime in 2018 we will hear from the FDA about this. The biggest limitation of this is that it's IV every 2 weeks. And I have not seen a dollar sign or a cost on this yet. Most monoclonal antibodies are crazy expensive. So I'm not going to talk about this a ton because when I think about how this is going to play a role in our practice, I I don't really see one, to be honest, but let me know if you disagree. It is nice because it doesn't really have effect on the liver and kidneys. It doesn't really have drug interactions. It doesn't really have any cross-resistance with other classes, but IV every 2 weeks, I'm skeptical that that's going to have a big role. The company that makes it is trying to create a more appealing version like a sub-Q version, but I haven't seen that yet. So finally, 2-drug oral maintenance therapy. You may have heard about this. You may have seen this. There's this sort of pendulum shift from our traditional sort of standard 3-drug therapy to now going back to looking at 2-drug treatment, either for initial ART or for maintenance therapy, meaning once somebody's suppressed, switching to 2 drugs. Let me just throw this question out there quickly. So patients, clients, whether you're a prescriber or not, I'm just curious, have you managed anybody on 2-drug therapy yet? Have you recommended this? Have you prescribed this? Just give a couple seconds to keep things moving. So 2-drug therapy, either as initial ART or as maintenance therapy. Have you done this yet? Okay, so I got 3 yeses actually. And this has been consistent with what we've heard on our ECHO program, that people are kind of starting to use this mostly sort of in unique situations, not necessarily routinely, but people are starting to employ these strategies. So why talk about this? Why study 2-drug therapy when we know 3-drug therapy works so well and we have so many single tablet regimens and options? So I think there is potential to reduce side effects, maybe reserve future options, though it's a little less compelling to me now that we have so many options. One really interesting thing to think about, though, is how much cost could be saved. And I refer you to this really nice modeling study published in CID, where they asked the question that, well, what if dolutegravir plus 3-TC or lamivudine 2-drug therapy turns out to be effective, which we're seeing it likely is. They estimated that 50% uptake of this combo as maintenance or initial ART could save many millions of dollars over 5 years. And simply as an estimate, if a quarter of individuals currently suppressed switch to this for maintenance over 5 years, they estimated we'd save more than $3 billion healthcare dollars. So I think there is some attention to this, especially in Europe where they're more focused on cost. I think that is a potential healthcare public health benefit. But I would also sort of ask the question, how necessary is this now that we have TAF, now that we have so many effective, well-tolerated agents? And I'll leave you to decide what you think about that. What I'm going to show you before we wrap up and have time for questions is simply examples of 2 studies of using 2-drug therapy either for maintenance or using 2-drug therapy as initial ART for people who are treatment naive. Let me start with the maintenance study because I think the FDA is going to weigh in on a combo pill of dolutegravir-rilpivirine in December. So I think there will be a dolutegravir-rilpivirine combo that is likely going to come out next month. So I do want to just highlight what we know about this. So one really important point is in these studies of 2-drug therapy, the participants are selected very, very carefully. So this is not maintenance therapy offered to just anyone. These are generally individuals who take their meds, who have been suppressed for a long time. In this study, the median time on ART was 4 years, and people had suppressed RNAs for at least a year. They were on only their first or second regimen. They could not have a history of prior virologic failure. Importantly, in this study, Hep B co-infection was not allowed because this certainly would not be an adequate or really give any activity against hepatitis B. So in these 2-drug therapy studies, people are selected very, very carefully. But those individuals who are in these studies, for example, in this one, were randomized to either 2-drug maintenance therapy. I say maintenance because these people are all suppressed versus continuing their 3-drug ART. You can see here that the virologic efficacy at 48 weeks was remarkably similar. Most of the 5% that was not suppressed here was, again, people with simply missing data, not virologic failures, people who'd stopped therapy for some other reason. However, there were 2 virologic failures in each arm. One in the 2-drug dolutegravir-rilpivirine arm had a significant NNRTI resistance mutation, though this individual clearly was not taking their meds because their viral load had spiked to 1 million. This was an individual who had previously been on a tripla, so it's also a little unclear whether this mutation was present at baseline and archived or whether it came out on therapy, so the investigators are looking at that. Interestingly, this person actually stayed on this 2-drug regimen and the viral load came back down. But I think what we see from this is that 2-drug maintenance for very select individuals can be effective, and with poor adherence, there is risk of resistance, not surprisingly. The switch from 3-drug therapy to 2-drug dolutegravir rilpivirine overall had a neutral effect on lipids, though we haven't seen a breakdown of people switching from boosted PIs versus NRTIs or anything of that nature. There was, not surprisingly, significant improvement in bone mineral density and biomarkers because the majority of people were switching off TDF to this 2-drug therapy. So here's my conclusion. This is the 2-drug regimen that we'll likely hear about in December and may become available. This is the trade name, which is being advertised broadly, so you've probably seen this in magazines and things. So will you use this? How will this fit into your clinical practice? I'll just throw that question out there because I don't think there's a right answer. When I've kind of talked to Bob Harrington and others, I would say personally I've been kind of a slow adopter of this, largely because we do have fairly well-tolerated 3-drug regimens with TAF, and I often don't see a huge reason not to add to this combo TAF or even FTC or 3TC, but I do think this is a viable maintenance strategy for very carefully selected people. What about starting with 2 drugs? So what about 2-drug therapy right up front? Again, I'll pose the question out there of, do we really need this? But people are studying it, so I want you to know about it. So there was initially a pilot trial in Argentina called PADDLE, which gave 2-drug therapy with dolutegravir lamivudine to 20 individuals, majority of whom had viral loads below 100,000 at baseline. And overall, it worked really well. So 18 out of 20 were suppressed at 48 weeks. One of these individuals who was not suppressed, unfortunately, was a suicide. The other had low-level viremia and in the end did suppress without a change of therapy. So really, it was quite effective, but a really small number. So that leads to this bigger pilot from the ACTG, which simply enrolled treatment-naive adults with a baseline viral load between 1,000 and 500,000. So that was the cap here. You can see about a third had a viral load at baseline pre-ART above 100,000. They did all get very extensive resistance testing at baseline, including integrase resistance, which we would not routinely do at baseline in the clinic. And they were simply all given dolutegravir plus 3TC as their initial ART regimen. You can see here it worked remarkably well. There were 3 participants with virologic failure. Interestingly, and we don't quite know what to make of this yet, interestingly, one of those who was in the viral load less than 100,000 group did develop resistance with a 184V and this integrase mixture, which makes it look like they're starting to develop R263K, which is the signature dolutegravir mutation. It doesn't have a lot of impact on integrase activity, including dolutegravir, but this is starting to become the mutation that happens when somebody does fail dolutegravir. What do we make of that? It was a mixture. This person clearly wasn't adherent. Actually, all 3 of these people clearly were not adherent to their therapy. But I think what we need to know more about, and this is being looked at, is what is the risk of resistance and virologic failure with these 2-drug strategies. So these were the investigator conclusions that dolutegravir and 3TC demonstrated potent virologic efficacy. Virologic failure was uncommon and was associated with suboptimal resistance. And these industry-sponsored trials are now going to look at dolutegravir 3TC initial therapy and try to get us more data and answers. So these are the questions I have about 2-drug therapy. What is that risk of resistance with suboptimal adherence? What's the efficacy in the central nervous system and other compartments? I haven't seen a lot of data on that yet. And I guess I come back to the question, too, how much do we need this now that we have other options? But is this the future? I'll throw this question out to you. This is simply a select list. This is not an exhaustive list of studies we've seen data from and that are ongoing of using 2 drugs either as initial therapy or as maintenance. So we've seen data. I showed you from 5353. We've seen data from Andes. It appeared to work well. Gemini is ongoing. We haven't seen data from this study yet, but we will soon. And then as maintenance therapy, we talked about the 2 long-acting agents for maintenance. And then these are a lot of studies that are ongoing, some of which we've seen data from, some of which we're waiting on. This one has now been published. I really only showed you the 2-drug studies that include dolutegravir or boosted darunavir because I think those are the ones I would actually consider, but there are other studies out there. And I know I'm pushing on time, so I mentioned ART monotherapy, don't do it. And there's lots of data out there and meta-analyses suggesting that monotherapy, even with dolutegravir, does lead to an elevated risk of resistance. So whereas with 2 drugs, most people who fail develop low-level viremia, don't develop resistance. That's not the case with monotherapy, so don't do it. What happens when TDF becomes generic? For time, I won't harp on this too much, also because no one really knows, but I do think we have to consider this as we talk about the future of ART. So when TDF becomes generic, there are lots of considerations, and there was a great talk at ID Week by Rochelle Walensky on this, and a really great paper by her group called The Epitaph for TDF, which I would refer you to. But my punchline there is no one really knows. So just to wrap up, I think that what's coming is some new oral meds in existing classes. How much of an improvement they are, I think is debatable. The long-acting ARVs, I am very eager to see and to learn more about, though I do have some skepticism and some questions about how we can incorporate those, especially for our most challenging patients. We will have a couple new agents in totally new classes for those who have very few options. And then, of course, I think what we really need is ongoing efforts to improve implementation, delivery, adherence, and things of that nature. And let me just quickly thank all of my mentors at Madison Clinic and the ATC, Chris, Carlos, and Julia for the technical support and patience with the polling, Liza for your help with organization, and I think we're right at 9. So I'll pause and happy to take questions or comments.